is Dr. Beth Bailey, and we have been working together for about 8 years.
Probably 8 years,
something like that. And I'm going to let you hear from her all the exciting things she's doing.
All right, I tend to wander, so can you hear me okay if I don't use the microphone? All right, we're going to stick with the theme here of maternal child health and talk a little bit about smoking and how you can work with women who are smoking, particularly pregnant women. But what I'm going to talk to you about today will apply to anyone. So this will work with men, this will work with teenagers. Okay, the basic idea is the same, but this is here specifically geared for pregnancy and pregnant women smoking. First thing I want to talk about is pregnancy smoking in general, give you an idea of how prevalent pregnancy smoking is and what some of the dangers are that are associated with pregnancy smoking. Okay, then we'll talk a little bit about interventions and the effectiveness of interventions, and then the bulk of this talk today will be on what you can do, so giving you some ways that you can talk to pregnant women about smoking. Then I've stuck in a little section about safe sleep, and you'll see how that's related when we get there. All right, so how big is the problem? Okay, how common do you think pregnancy smoking is in this region? Of all the pregnant women in the region, say Northeast Tennessee, what percentage do you think smoke while they're pregnant?
45.
Wow, I'm hearing some big numbers. I heard 45. Did someone say 75? Wow. All right, that's high. Fortunately, it's not that high, but the 45 was close. All right, so we know that nationally about 11% of pregnant women smoke. Okay, so nationally, quite low. In Tennessee overall, 17%, so about 50% higher. Northeast Tennessee, we are in the 30%. If you go to some of the rural counties in Northeast Tennessee, the rates are in the 40s. Okay, so we have at least 2 out of every 5 probably pregnant women smoking during pregnancy in the region. So it's a pretty big problem. All right, so just to give you a real quick idea here about cigarettes and the dangers of cigarettes in general. Cigarettes contain over 4,000 chemicals. Some of these naturally occur with the natural products that go into cigarettes. Others are added as a result of the processing. Most of these are carcinogenic. So if you start looking through this, acetone, which is a nail polish remover, all of these things are in chemicals that are in cigarettes. And so when you smoke, you are ingesting these. When you smoke when you are pregnant, not only are you ingesting these, but the fetus is ingesting these. All right, so when we start talking about the dangers of a smoke-exposed pregnancy, it's important to recognize that there are effects during gestation. So the fetus is affected, and I'll talk about what some of those effects are. But it's important to recognize that the effects continue throughout your life. So a baby who is exposed prenatally to smoking will have problems when it's born, problems in infancy and childhood, and then these things, new problems, will tend to emerge throughout their life. Okay, so this is something that is lifelong in terms of an effect. Here's some of the domains that are affected. So when we look at a child who's been smoke exposed, they are at higher risk for problems in all of these domains. So whether it's health effects, whether it's things like emotional regulation, attention, behavior, growth, all of these things can potentially be affected. So what are some of the risks to a pregnancy? What can happen in pregnancy if you smoke? Okay, there are increased risks of all these things here that are listed. Now that is not to say that every woman who smokes during pregnancy is going to have these things happen, but it's an increased risk. And for many of the problems, it's a substantially increased risk. Intrauterine growth restriction is the one we talk about a lot, so the fetus not growing as it should. Okay, almost all smoke-exposed pregnancies have some level of intrauterine growth restriction. We see a lot of spontaneous abortion and miscarriage. The 2 bottom ones, obviously, if the child survives the pregnancy, we end up with high rates of preterm delivery, early gestational age, and low birth weight. Give you an idea of the effects here. So we talk about smoking being a causal factor. Now, for those of you who are research savvy, and you think about what it takes to say that something causes something else, we usually need a controlled study. So we would need to randomly assign people to smoke during pregnancy and randomly assign other people not to smoke during pregnancy. Ethically, we can't do that kind of study. So we don't have randomized control studies that tell us this. But what we have is decades of evidence where we start ruling out and controlling for other factors. Plus we have animal research, okay? So you can do some of these experiments with animals. So the opinion in the medical field now is that smoking does cause a lot of these birth outcomes. Okay, as I said, birth weight is one of the things that's most significantly affected. We see for someone who smokes maybe 10 cigarettes a day or fewer, anywhere from about 200 to 250 gram birth weight deficit. Okay, so these babies are smaller. For a heavier smoker, a pack a day or more, we might see 400 grams. Okay, that's a pretty substantial difference when you talk about a birth weight of about 2,500 pounds or 2,500 grams. Also see a significant impact on preterm delivery up to 10 days early. So these babies come early and they're smaller in not beyond the proportion for being early. Okay, so there is some gestational growth restriction. We see significantly decreased APGAR scores, doubled NICU admissions. Obviously, if you've got this birth weight deficit going on in the preterm, we see more NICU admissions for babies born to smokers. Okay, and this is what really drives this. Okay, so if we have a baby who's preterm, you've probably seen some of these numbers before. Okay, number one cause of prematurity is smoke exposure. And so we see that babies that are preterm, these are healthcare costs during the first year of life. Look at the difference. Okay, so this is not only a health concern for the baby and the mother, but this is a public health concern in terms of healthcare costs. All right, so what happens when the child is born? Moving through childhood, we have our little baby here with an ear infection. Ear infections are very common among children who were smoke exposed prenatally. Allergies and asthma, we have our little girl down here getting her asthma treatment, or possibly oxygen, I suppose. We see growth restrictions. So these kids are born small. By age 7, they still haven't caught up. Okay, so they tend to be about an inch shorter by age 7. We have increased rates of sudden infant death syndrome. In fact, and I'll get to this near the end, about 1/3 of SIDS cases can be directly attributable to prenatal smoke exposure. Okay, so there's a lot we can do with SIDS reduction when we address smoking. Okay, now take a look at the bottom bullet point. We have small children. They're being born low birth weight and they're being born short. But we have increased rates of obesity as these children move through. So the body is primed biochemically to start putting on weight. And in our local data, when we assess children of smokers at 15 months of age, we were already starting to see increased rates of children being too heavy. Okay, so it starts early. All right, so what are some of the effects as children move perhaps into school age? We start to see a lot of problems in school. These kids are at higher risk for lower IQ and language delays. We see attention problems. This seems to be the #1 reason why kids are diagnosed with ADHD. We see elevated levels of depression and anxiety, and then all of this obviously is going to lead to a lot of behavior problems. Children with prenatal smoke exposure are almost 3 times as likely to have encounters with juvenile authorities. Okay, so there's some emotional regulation problems there going on. And as they move into adolescence and adulthood, we see increased rates of smoking. Some of this is obviously modeling, because if they were exposed prenatally, they're probably exposed postnatally. But there also is a fair amount of research that is showing us that these children are kind of primed biochemically to be more likely to start using substances and to become addicted when they do. All right, a few final notes here. Amount and timing are important. So we know that the more a child is exposed to prenatally, the more the mom smokes, the more likely the effects, the stronger the effects. Okay, so what that tells us, one, is that any amount of cutting down can be good. Okay, but we do know that with as few as 2 cigarettes a day, we see effects. So obviously quitting would be the ultimate goal. But timing is also important. You hear a lot about early pregnancy being a problem for teratogens, anything that could influence the fetus. And alcohol is one of those. You see a lot of effects for a woman who drinks early during pregnancy. However, for tobacco and opiates, I threw that in there because that might be of interest, late exposure tends to be more important. So children who are exposed in the 3rd trimester during their gestation are more likely to have effects related to smoking. And so what that tells us is that interventions could likely be useful, because if you can intervene with a woman and get her to stop smoking sometime during the 2nd trimester, you're more likely to have improved birth outcomes. All right, something else to mention. How many of you have heard of third-hand smoke? A few. Okay, this seems to be a new term that we're seeing a lot of. Secondhand smoke you all probably know about, right? That's the smoke that's in the air when someone else other than you smokes that you inhale. Third-hand smoke is actually the contamination that remains on surfaces from what is put out by a cigarette. So there is residue that may be seen in environments where there's a lot of smoke, but even in environments where there's not a lot of smoke, you may not see it, but it's there at a very small particle level, and it gets on surfaces. Okay, we have seen that women who are exposed only to third-hand smoke during pregnancy have some of the effects of women who actually smoke themselves. So we start to see children who can be exposed to this third-hand smoke, that it can be just as damaging as the smoke in the air. So obviously this is important when you're working with a pregnant woman who says, well, I live with smokers, but they don't smoke when I'm in the house. If they're smoking in the house, they're contaminating the environment and they're leaving residue on the surface. So it's important to remind women of that fact. A couple things in terms of whether or not intervention works. We know that smoking is the most modifiable risk factor for poor birth outcomes. So when a woman smokes during pregnancy, the one best thing you can do for the health of her fetus is to encourage her to quit smoking, more than any other behavioral recommendation you could make. Okay, we find that when we do treat tobacco dependence and women are able to give up smoking, that we see a lot of improvements in birth outcomes. Locally, we've had an intervention, which I'll talk about in just a minute, that went from 2007 to 2012. So I gave you the U.S. and the Tennessee rates. This was the rate of smoking in Northeast Tennessee in 2007. In 2012, we achieved a fairly significant reduction in pregnancy smoking rates in the region. And that corresponded to an improvement in the low birth weight rate and the preterm birth rate. Okay, so you can see that Northeast Tennessee in 2007 was ahead of the state average for both low birth weight rates and preterm birth rates, and those have actually come down since we've instituted a lot of these reforms that have led to a pretty significant drop in pregnancy smoking. All right, so the TIPS program, the Tennessee Intervention for Pregnant Smokers, was funded from 2007 to 2012 to address the very high rates of smoking, pregnancy smoking in the region. This was actually instituted by the governor's office in 2007, and they had set up this infant mortality task force, and they were looking at ways in different regions of the country, what were the important things that were leading to significant infant morbidity and mortality. And in the Northeast, it became very obvious that pregnancy smoking was one of the leading causes of that. So they sunk a fair amount of money into addressing this problem in the region. Now, the program itself was multifaceted. We did a lot of things in terms of provider training. We did a lot of community outreach. But the most successful component was actually placing smoking cessation counselors in practices. We had great success with that type of model. And obviously, as funding ran out, we were looking for ways to transition. And so we've been doing a lot of provider training, physicians, nurses, to get them to kind of take on a counseling role in a prenatal care setting. But what our counselors did specifically was they assessed and intervened, and they used the 5 A's model, which I'm going to go through in just a minute. But some other things that they were able to do that a provider might not be able to do in a limited amount of time is address other things like life stressors and mental health issues, because we know that if a woman is stressed, if she's depressed, if she doesn't know where she's going to be sleeping that night, the last thing on her mind is trying to give up her cigarettes. And so we have to work with some of these other issues before we can have somebody who's ready to quit smoking. And so as you start trying to do this with pregnant women, you'll recognize that your success rates are going to be very low because there's a lot of barriers to people quitting smoking, and so you need to be mindful of that. And working with family members was also very important too. You could get a woman to quit smoking, but if she goes home and there's smoke in the environment, not only does she have the secondhand smoke, but that serves as a trigger for her to possibly relapse. So it's also important to work with family members. All right, so what we found, this is comparison here of birth outcomes for the women that we worked with that quit smoking, reduced smoking, and continued smoking. And as you can see, we had pretty significant gains in both birth weight and birth length among the women who quit smoking. Okay, so all of these women started pregnancy as smokers. These who quit by about 24 weeks. These are the ones who reduced, and you do see some gains there as well, especially for preterm birth rates. If we could even get them to cut down their smoking, we found that the preterm birth rate went way down. NICU admissions. Now, keep in mind that this was about 4,500 women total over the 6 years. Among our women who quit smoking, we didn't have a single fetal or neonatal death. Okay, now some of that was probably chance and we got lucky, but it's been a nice thing to be able to say in terms of comparing that to those who reduced and those who continued to smoke. All right, now here is secondhand smoke. So we also worked with women who didn't smoke themselves but had significant secondhand smoke exposure, and those who were able to substantially reduce or eliminate it had much better birth outcomes than those who continued with their secondhand smoke exposure. Where we see the biggest here is obviously with the preterm birth and the NICU admissions, and obviously the NICU admissions is a big one that you want to target. Something else very important is that we've demonstrated the relative impact of smoking in relation to other substances. A lot of times what we hear from providers is that they don't address smoking with women because the women are using marijuana, they're misusing prescription drugs, and they think I really need to address these other things and we'll deal with the smoking later. Well, what we found, and this was a paper that I actually published with Dr. McCook, is that when you really try to parcel out the birth weight effect due to different substances, smoking has a bigger effect on birth weight than any other substance you could use during pregnancy. Okay, so I'm not saying it's okay to use marijuana or use cocaine during pregnancy. Okay, but what I am saying is when you're targeting substances, you need to include tobacco as one of those substances that's important. We asked patients what their preferences were because we started out very naive in 2007 and thought, oh, we'll set up smoking support groups and we'll do all of these other things. And a lot of this stuff wasn't really well received by the women. Okay? Most of the women in this region were not interested in going to a support group, which to me was a surprise, until I learned a little bit more about the culture and understood the private nature that goes a lot with the Appalachian culture. And there was a real strong preference for individual discussions with healthcare providers. Okay, so group stuff, not so much, much more with individual discussions. Most of the pregnant women we talked to came to us, they knew the dangers of pregnancy smoking. Maybe not all of them, maybe not to the effect, but they knew they shouldn't be smoking during pregnancy, but they were unable or unwilling to quit. Most of them were reporting unable. Most of them said that their providers did talk about smoking with them, but the discussions didn't go far enough. So having someone come to you and say, related to an addictive behavior, you need to quit, okay, that's nice, but that's not all that helpful. You need assistance, you need some help with moving forward with the behavior change. And so that's what all of these women were telling us. All right, a few final thoughts here. I bring this up all the time now because this has come up in the past few years. We had a few providers in the region that were telling pregnant women that they should not quit smoking while they were pregnant because it would be too stressful for the baby. I was surprised at that. Yes, there is a certain amount of stress with withdrawing from any substance. Quitting can be stressful, it can be hard. We know the studies on cortisol and what it does to fetal development, but if you look at the effect of stress, the magnitude of the effect of stress versus the magnitude of the effect of what the smoking is doing to the child, a woman is much better off quitting smoking during pregnancy. And both the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics, both of them say unequivocally that a woman should never be told not to quit smoking during pregnancy. Okay, so if you hear that, okay, you can cite both of these organizations to say no, you really do need to try to quit. Here's some cessation rates just to give you an idea of what you might be able to expect. Okay, brief one-time advice and practical tips from a trusted healthcare provider, much like what I'm going to give you right now. Quit rates of about 10%. Okay, doesn't seem like a lot, but if 10% of pregnancies you could save a fetus from this exposure, great. So if you're working with pregnant women and you're getting discouraged that nobody's quitting, if you can find 1 out of 10 women to quit smoking, you're doing well. Okay, smoking quit line, quit rates of about 10%. Okay, that tends to be fairly effective too. So if you combine that, if you also tell women about the quit line, you might see higher rates. Dedicated counseling like the TIPS program, quit rates of over 30%. So women that we met with only one time, a counselor met with them only one time, our quit rate was about 28%. When they met with a counselor 4 or more times, we had almost 40% of women who were able to quit smoking, which is huge for an intervention like that. Okay, regular brief intervention sessions like the 5 A's from a trusted professional. So instead of just one, if you do it every time you see them, we see quit rates of about 20%. Okay, the important thing is here, as you can see, obviously a one-time shot, great. If it's regular and consistent, even better. So what can you do? The 5 A's approach to smoking cessation, it was developed for smoking. It has now been applied to a lot of behavioral interventions. But what it is it's a brief motivational interviewing session. So by brief, I mean 5 to 15 minutes, usually 5 to 10 is adequate. It's been proven effective for pregnant women to help them quit smoking. All right, they're consistent strategies that were developed by the National Cancer Institute, and then ACOG modified them for use with pregnant women. All right, so what are the 5 A's? Here are the 5 A's. These are the steps that you would use in talking to a pregnant woman about smoking. So the first thing you do is you ask her about tobacco use. Okay, you need to know who to talk to first, so you need to know who is smoking. And I'll go through these in more detail. Then second step is you advise them to quit. Third step is you assess their willingness to make a quit attempt. And this is very important because if you don't know how willing they are to quit, you don't really know how to help them. So the next step is assist, and then finally arranging for follow-up. All right, so let's go through these. Asking about tobacco use. All right, probably all of you have seen healthcare providers, either in your own experience as being a patient and your own experience as being a nursing student, have seen healthcare providers ask patients about their health behaviors. Okay? There's some health behaviors people are fine talking about. There are other health behaviors that people are a little more reluctant to talk about. Okay? If you're being asked about whether or not you do something that is considered unhealthy, is something you shouldn't be doing, the natural tendency is to not necessarily be completely honest, right? Okay, there's the social desirability factor. So if you ask a pregnant woman the question that is actually on the ACOG form for intakes in prenatal care, the question is, are you currently smoking? 40% of women who are smoking will deny smoking when asked a yes or no question. Okay, your natural tendency is, nope, I'm not doing that. I shouldn't be doing that. I'm not going to tell this healthcare professional who's standing here looking at me that I engage in this unhealthy behavior. Okay, so there's a lot of social desirability responding. What we've found is that if you can ask the question and give multiple response choices, we tend to get more honest answers. And what the key here is really these last three categories. You're giving women the option to report that they've done something positive. Okay, so if a woman maybe smoked a pack a day at the beginning of pregnancy, and now she's smoking 18 cigarettes a day, okay, 2 less, she's able to not tell you this last category, but this category, okay? So she can feel good reporting that she's made a behavior change, even though she's still smoking at quite a high level and should be targeted for intervention. Okay, so if we can separate it out like this, we tend to find that women are more honest. We tend to see only about a 10% denial rate if we use a question like this. Okay? So the first three, if they give you one of those first three responses, you congratulate them. Now, people here, in particular, in the middle group, relapse rates are very high. Okay? If any of you smoke and have quit, you know that relapse is very common. It takes about 5 times quitting before you actually are successful at your quitting. And so women who have recently quit really need to be encouraged and followed up with every time to make sure that they haven't relapsed. All right, so these women here, though, are the primary target. So if they're reporting that they're smoking, even if they have cut down some, that's when you move to the advised step. All right, we can use the same type of format with secondhand smoke. Okay? Same type of thing, just broken out a little bit different. So after someone reports that they're smoking, the next thing you should do is give a clear, strong, personalized advice to quit. Okay? So what does that mean? Now, you would be surprised at the number of women that we know that healthcare providers have told them that they should smoke will report, no, my doctor didn't tell me that. I didn't hear that. Okay? You're engaging in a behavior you don't want to give up. You're going to hear what you want to hear. So if you leave any ambiguity, anything open to interpretation, it could be misinterpreted. So it's very important to be very clear in your advice. So a statement like, as your healthcare provider, my best advice for you and your baby is for you to quit smoking and reduce your secondhand smoke exposure. No ambiguity there, it's pretty clear, okay? I need you to know that quitting is the most important thing you can do to protect your baby and improve your own health, okay? It's positive, it's not nagging, it's just a nice, clear, positive statement, okay? Something also important to do at this step is to personalize it. So start talking about the impact of smoking on the baby. This is where you bring in some of the information I provided earlier about the risks you're putting your fetus at, the impact of the smoking on the family and the patient's well-being. So, you know, women will quit for the fetus. This is a time when they're highly motivated. There's somebody else that they are impacting, but their own well-being is also important too. So it's important to talk about that. All right, so that's advice. Okay, I mentioned that the yes-no question on the ACOG form, if you start working in any of the prenatal practices in the region, we've gotten the ACOG forms adapted that actually include this response choice question. We get the amount of smoking and then the secondhand smoke. So this would be another way to introduce that on the forms or in the electronic health record. All right, so assess. Assess the patient's willingness to quit. Because if you ask most smokers, do you want to quit? 90% of them will tell you yes. Okay, but if you pin them down to, are you willing to quit in the next 30 days, you'll lose a lot of them, okay? So if you make it very specific, and obviously pregnancy is a window that's important. We want a woman to quit as soon as possible. So it's important to frame it in terms of how soon are you willing to quit. All right, so this is one way that you can assess their willingness to quit. Give them a scale, like a 10-point scale. How willing are you to quit smoking in the next 30 days? Are you 0, not at all willing? I guess this is an 11-point scale, isn't it? Or 10, extremely willing. All right, most people are going to answer somewhere in the middle. But this gives you a sense. You're going to then proceed very differently with someone who says 10. Okay, this is someone who is ready to quit, needs some tips on how to do it. Somebody who tells you a 3, not so ready, is probably going to need you to motivate them a little, give them some additional reasons why they should quit. So you'll approach it differently depending on the answer you get here. Now, one way to start continuing the conversation might be to say, what would it take to make you more willing to quit to get you to move from a score 3 points higher? So say they give you a 4. Say, what would it take for you to be a 7? What would have to happen in your life? What would you have to do? What would you have to know, okay, in order to move from a 4 to a 7? It starts getting them thinking about the behavior change. All right, so as I said, if the patient responds they want to quit in the next 30 days, you move on to assisting. If they respond that they don't want to quit, and I'd put anybody 5 and below probably in that category, try to increase their motivation. So educating them some more. Here's what you could do to increase your baby's health. Here's how your baby's health would be increased if you would quit. Trying to frame it in the positive rather than the negative. There's mixed research on this. A lot of times people will view it as lecturing and badgering. If you say, if you don't quit, this is what's going to happen to your baby. It tends to be viewed a little bit more positively if you frame it as, if you quit smoking, your baby is more likely to be a normal birth weight. Your baby is less likely to have ear infections. Your baby is less likely to have this. Okay, so personalizing it, helping increase motivation. One of the personalizing things, if you have a woman who has another child and she's been smoking the whole time, you might want to inquire about that other child. Does your child have a lot of ear infections, a lot of respiratory infections? Does your child have asthma? So kind of personalizing that and pointing out that that may be because of the smoke exposure, and maybe you could have a healthier option for this second baby. All right, so we move into assist. So we've got someone who maybe we've at least motivated up to a 5 or so, and looking at whether or not they are willing to quit and how we can assist them. All right, so some of the initial considerations. One thing you need to think about is that addiction is both physical and behavioral. So has everybody had a class on addiction yet? I don't know where you are in your curriculum yet. You probably talked about addiction in some class. Okay, so when we talk about addiction, and nicotine is highly addictive. In fact, nicotine, I don't know if you know this, nicotine is actually more addictive than heroin. Okay, so this is a highly addictive substance, very hard to quit. The physical addiction is only part of it, though. There's a behavioral addiction. Now, all of you, I'm sure, are familiar with behavioral addictions if you think about it. If you've tried to lose weight, if you've tried to increase exercise, if you try to do any of these things, think about all the things that keep you from changing your behavior. Okay? I'll give you an example. My husband and I went on a diet the first of the year. And so I have found I did great the first week because I was home. I wasn't at the university. I was home. I could, set things up. Then I came back to work. And all of a sudden, I'm sitting at my desk, and I realized how much it is habit for me to sit at my computer and reach for something to eat. Okay, that would be a behavioral addiction because you've got to somehow break that pattern. So with smokers, the behavioral component might be every time they get in the car, after they finish a meal, okay, whatever it is that's triggering them to smoke. So you need to recognize that when you're working with somebody with an addiction. All right, both factors have to be addressed for successful cessation, and then the assist technique should be chosen based on the patient's willingness to quit. So again, if they're very willing, they just might need some very specific pointers. If they're less willing, you've got to really help with the motivation. Some strategies that some women find helpful. Okay, first thing you need to do and think about before you ever start working with pregnant smokers is what's your own personal bias related to the issue. Now this could go in both directions. You could be one of these people that cannot believe that a pregnant woman would smoke, that she would do this to her fetus, that she would put the fetus at risk. Okay? You might be on the other end. You might be a smoker yourself. You might have smoked while you were pregnant. Okay? So you may be in very different directions on the scale, but it's important not to let that interfere with how you deal with the patient. Okay? So don't come off as critical and judgmental. You need to be open. You need to be encouraging. But also, if you yourself are a smoker or even smoke during pregnancy, make sure that you're not tacitly condoning the behavior because that kind of lets you off the hook, okay? So it's important to really recognize your own biases. All right, discuss the dangers and the costs of smoking and secondhand smoke, and I'll get to some examples of that in a minute. Discuss the benefits of quitting. What will she gain from quitting? I'll give you some examples of that. Okay, determine the role that smoking plays in her life. And this is really important, and until I got into smoking cessation, I didn't really get this piece of it because I had never smoked myself. For a lot of people, smoking is more than just smoking. It becomes a social activity. So it's something that you do with the group of people that you go out and smoke with. Okay, and then all of a sudden you quit and you don't have that social interaction time. And that can be a very powerful factor pulling you back to smoking. A lot of women report that they smoke for stress relief. Okay? You're pregnant. If you have a lot of other challenges in your life, a lot of the women that you'll work with in this region have a lot going on in their life and a lot of challenges and a lot of stress. And so they smoke to get that stress relief. So it's important to recognize that smoking plays a positive role for them in terms of social interchanges, in terms of stress relief, and you need to help them recognize that, one, and to two, help them find some substitutes for that. Okay, so okay, is there maybe everybody goes out at work and smokes? Is there a coworker who doesn't smoke that maybe you could do something with during that time? What else can you do for stress relief? And talk about some of the things, some of the more healthier things someone could do for stress relief. All right, discuss her motivations for quitting. So really, again, personalizing the issue, wanting the baby to be healthy, playing up, seize on whatever it is she says that might be important for her to quit. All right, whoops. Okay, one of the things very important is to identify triggers and roadblocks. I've hinted at this already. So every time she gets in the car, is that the time when she picks up the cigarette? Every time she's tried to quit, has it been the spouse that's encouraged her to go back to smoking again? What are her triggers and what are her roadblocks? Finding those, talking about them, working through them, finding other solutions. Okay, determine what she can do in situations when she usually smokes. Again, if it's in the car, what can you do? Can you listen to something? Can you, whatever it is. Discuss alternative behaviors to smoking. Plan ways to relieve stress and cope with difficult emotions. So recognizing that quitting is going to be stressful and having that conversation up front, because if you aren't expecting it to be stressful and you're a day in and all of a sudden this is overwhelming, you're much more likely to go back to smoking. So what can you do to relieve stress during that initial period that's going to be very difficult? Okay? Whether it's exercise, taking time for yourself, anything like that that can help keep her active and doing something else. Okay, as you count down to your quit date, so you get out a calendar and say, okay, this is the day that I'm going to quit. What are the things you're going to do leading up to it? Okay, so you're going to stock the fridge with healthy food, and you're going to remove all the tobacco products from the environment. If she's still got that pack of cigarettes in the glove box of the car, day 2 into quitting, they're there, and then it becomes easy. So if you can help take care of some of that ahead of time. Identify and arrange social support. If she can find somebody to quit with, great. A quit buddy is probably the best way to go. But even if not, finding other people that will help support her in this change. Determining the quit date and signing a contract. Now, we did this with women, and it tended to be fairly successful, which on the face of it, you would wonder why. I mean, it's not like this is a legally binding contract. They signed this, but we had them sign it, take it home, put it on their fridge. It was right there in their face, a reminder. And people, once they put it down in writing, tend to be more likely to follow through. All right, so what are some other things you can do? Self-help materials are very good. A lot of people trying to quit just really need some tips and advice and maybe something to read when it gets very stressful and a hard time. There's a lot of pamphlets. American Cancer Society puts out a lot of stuff. ACOG puts out a lot of material. We put together this book for the TIPS program, and I'm going to leave a big box of these with Dr. McCook if you're interested, if you start working with women and find it would be helpful. This is something that will give you a way to work with them. You could copy pages to give to the women. It's got some of the stuff I've been talking about already here. But anything you can give them to kind of take home, to think about it, to keep it in their mind. Well, some of the things in here talks about the health benefits, a timeline for that, withdrawal symptoms, how to cope with them. I'll show you a few of these. Cost savings, that's one of those that's very important. Alternative ways to cope and manage stress. How to quit without gaining weight. A lot of women get really concerned, if I quit, am I going to gain weight? Pregnancy is the best time to quit then, right? You're already supposed to be gaining weight. Dealing with others smoking around you. Sometimes that's very hard for women to navigate. And just how do you go about preparing to quit? All right, so here's an example of a page from the book. The health benefits for both the mother and the child. So if the mother quits while she's pregnant, her baby will. Here's all the things you could point out. Your baby will benefit in these ways if you quit smoking. Get more oxygen, be protected from this, have fewer doctor visits. Whatever it is that you think she noticed, and kind of play on that. Okay? Patient's health, obviously, she's still going to be concerned about her own health. Here's some of the things that she can obviously expect if she quits smoking. All right, here's the timing of the health benefits. And this has always surprised me. Within 20 minutes after you finish a cigarette, your blood pressure and heart rate return to normal. So you could maintain that indefinitely. Within 8 hours, you have oxygen levels returning to normal, nicotine levels reduced by half. You get everything here eliminated from the lungs. Within 48 hours, nicotine's out of the body. So that sometimes, getting to the 48-hour point is often very hard for smokers because that's when all the cravings and the withdrawal are happening. So encourage her that if she can make it to 48 hours, that nicotine is all out of her body. Okay? Within 72 hours, breathing is easier, energy levels increase. All of these things, you've got health risks out to 15 years. Again, so for some women, this might be something that interests them and something to play up. All right, if you look at the average cost of a pack of cigarettes, which is over $5 now, so a conservative estimate of $5. If somebody smokes a pack a day, they spend nearly $2,000 a year on smoking. Okay? A lot of smokers, while they know how much their cigarettes cost, when you put it to them like this, are very surprised at the amount of money that they spend. So for a pregnant woman, this is something you can really use. You got a pack a day smoker, you know, maybe she's 6 months more to go in her pregnancy. She could save $1,000 by the time the baby's born. Okay, talking about what could you do with $1,000? Okay, a lot of us could think of a lot of things we could do with that kind of money. So personalizing it and making it so that they see, here's another benefit. All right, other things you can do. Recommend that they keep their hands and their mouth busy. Okay, this behavior like this, you get very used to it. Keeping your hands busy, drawing, a stress ball, you know, anything you can do to encourage them for the first week or two to keep their hands busy, and the mouth. And this is why people gain weight, because they're so used to having something in their mouth all the time. So, you know, whether it's gum or candy, something low calorie, drinking water, you know, if they need to eat, trying to encourage healthy foods so that they don't have the problem with the junk foods, I guess, while they're trying to quit. All right, how do you deal with other people smoking around you? This is often a huge challenge for women in this region. Many of the women that we have dealt with in the practices in the region have a really hard time navigating control of their environment. Okay? Many of them are in relationships where the male is mostly in control, or they're living with parents. They're in a situation that isn't necessarily completely under their control. And so it's very hard for you to tell them, you need to tell everybody to quit smoking around you. Okay? That may not be possible. They may not live in their own house. They live in somebody else's house and can't tell them what to do in their house. So helping them find ways to navigate, even if it's creating a smoke-free zone. Car, really important, because that's such a confined space. If they can just get people to quit smoking in the car with them, or if they could have smoke-free rooms in the house. Go places where smoking's not allowed, which is fairly easy to do now in Tennessee with all of our Clean Air Acts, and surrounding yourself with non-smoking friends. So if somebody says, well, yeah, but all my friends smoke, well, do you have any friends who don't smoke? Maybe that's somebody you could reach out to over the next few weeks and do some things with. So, you know, anything you can do to give advice and tips to help her be more successful. How to quit without gaining weight, as I mentioned. Keeping a food diary, very important if you've ever tried to lose weight at all. That tends to be the best motivator. If you have to write it down on a piece of paper, you'd rather not put it in your mouth. So having them keep a food diary, staying busy and physically active, obviously that will counter a lot of that. Drinking water, good nutrition, and talking. It may require a discussion from you. You all know about good nutrition. Talking about what is good nutrition and what are some healthy snacks they could substitute instead of smoking. So how do you deal with things like this? This tends to be one of the most common things we hear. And you tell a woman, well, you really need to quit smoking. And she says, well, I smoked with my first child and he was okay. Or my mom smoked with me and I turned out okay. All right, this becomes a little difficult to navigate because you need to be careful. Okay, you can get resistance very quickly and have somebody completely shut down if you say, well, you got really lucky and you shouldn't, you know, you need to be careful how you say it. And so if you start talking about, and you can make it more of a medical discussion, what we call it is varying susceptibility. And so every pregnancy is different, which means that tobacco can influence every pregnancy differently. Okay, there's some things that affect the susceptibility that we know of, and I'm sure there's many that we don't. Okay, so maybe during her first pregnancy she smoked but had no secondhand smoke exposure, and now she's got a whole bunch of secondhand smoke exposure. So she's increasing the amount of tobacco this child's exposed to by smoking. Okay, maybe she's under more stress. We metabolize differently when we're stressed. Okay, smoking is actually more harmful to the baby when you're stressed than when you're not. Nutrition. There's a lot you can do nutritionally to counteract the effects of tobacco in the body. Vitamin E is one of them. And so if she's eating more poorly this time around, she might be more likely to have effects. Increased age is the biggest one. And so as women get older, there's a lot more insults to pregnancy. And if you smoke when you're 25 and pregnant, the kid may turn out fine. If you smoke when you're 35 and pregnant, you are much more likely to have problems. So particularly with older women, it's very important to have the discussion about how it's much more harmful as they're older. Environmental factors and overall health. Somebody healthier obviously has more mechanisms to help protect the fetus. All right, so pharmacologic intervention. We often get the question, is it okay to use nicotine patches? Can I use Chantix and all of these other drugs while I'm pregnant? The general answer is no, but with a few caveats. So we recognize that behavioral intervention is the first line. We always want to start with a behavioral intervention with a pregnant woman. But if you've got a 2-pack-a-day smoker who's tried everything, who can't seem to quit, that might be a time to consider pharmacotherapy. Now, you have to be very certain, and providers have varying opinions on this, that the woman's not also smoking while you're giving her nicotine patches, okay? And this is what this is here. I don't know how well you can see it. Basically, this is the guy who's got nicotine patches all over his body. He's not taking them off. And so we want to make sure that by giving them nicotine patches, we're not introducing the infant to more nicotine than they would otherwise have if the mom were just smoking. There's very limited data on the safety of these drugs during pregnancy because obviously we're not doing clinical trials with these for the most part. We do know that nicotine gum seems to be the safest. So if a woman is pregnant and wants to use something to quit smoking, nicotine gum is the best way to go. Very much discourage things like nasal sprays because they very instantly get into the system. And the patches are really not the first choice either because you've got this continuous dosing. And Chantix, Zyban, no. Most providers will not prescribe them under any circumstance. There's a few who will, but they really shouldn't because there's really no safety data on them. All right, so after you've walked through assisting, now I've spent a lot of time on this, but truly you'll pick and choose from this menu of options and you can do it much more quickly with a woman. But once you've gone through the assist phase, the next thing you want to do is arrange. And what this means is you're arranging for her to have other resources away from you and potentially, given the nature of your relationship, a follow-up with you. So asking permission if you can talk with them about it again. Making sure that they have a support system, they have a place to go and ways to get information. Tennessee Tobacco Quit Line does actually have a special program for pregnant women. So if you give the woman the information, tell her when she calls in to identify herself as being pregnant. So some other helpful tips, encouraging to be smoke-free. I have had some discussions with a lot of people in this field. Many people are very militant and say, no, the only approach you should have is tell women they have to quit smoking. And that we're not going to have a discussion about cutting down because any amount of smoking is dangerous. All right, it is true that any amount of smoking is dangerous, but that may be all she's able to do. And when I showed you what can happen when you cut down and what the effects can be, it's important to recognize that as an option. So obviously you want to start the conversation talking about quitting, but if she's not willing to go there, it's okay, I think, to talk about cutting down and talking about having a discussion about what can you do to cut back. Praise any quit attempt, even if it's for only an hour. Okay, if she is a chain smoker and went an hour or two without smoking, that's a success, and so find ways to reward that. Okay, acknowledge how difficult behavior change can be. A lot of times people just need to hear, I know this is hard, and I know this is going to take work, and I think you can do it. So how do you integrate the 5 A's into what you're doing? So encouraging to be smoke-free, counsel them to quit down if they're unwilling to quit, praise any quit attempt. Okay, another thing you can do is let the provider. So if you are in this situation as a student or once you become a nurse, make sure the provider that they are seeing that day knows their smoking status. You'd be amazed at how many providers really don't ask and don't ask that often. And so if you found that out, you can inform that provider and say, look, this patient is smoking but is thinking about quitting. Could you encourage them? Could you provide some tips and advice? Acknowledge again how difficult behavior change can be. Explore any benefits of staying the same as well as of changing. A lot of women will tell you that they get a lot out of smoking. You know, whether it's the stress relief, whether it's the social stuff, there's a reason why they've continued to smoke. And so you really need to explore the benefits of what they get out of smoking. Gather information about smoking status and readiness to quit at every appointment. So again, that consistency is important. All right, so here we have a patient. We have a patient that reports she smokes a pack per day and has 2 previous quit attempts. In one attempt, she was able to remain smoke-free for 32 hours. She reports that she's very interested in quitting now that she is pregnant. How can you assist her? What might be the first thing you do once you go through asking her about her smoking and assessing her willingness to quit? Well, you advise her and assess her willingness to quit. If you move into the assist phase, what do you think you could do? Praise the quit attempt. That's really the key here. 32 hours is a long time, especially if she was smoking a pack a day. Okay, that's what, a pack and a half probably that she actually didn't smoke. Seize on that positive, that success. Okay, that is great that you were able to quit for 32 hours. How were you able to do that? You know, what were the things you had in place that made that possible? Okay, so it sounds like whatever that is that she tells you was really helpful. What do you think kept you from making it past 32 hours? So what happened at 32 hours? Look at what that trigger, what that barrier was at 32 hours, and talk through that with her. How can we avoid that next time? Okay, what do you enjoy doing that might help whatever it is during this quit attempt? So if she says, okay, I went to a party and everybody was smoking and I smelled the smoke. All right, so what do you do next time? Maybe avoid social situations where they're smoking for a couple weeks until you're over that hurdle. Or going somewhere with a friend who doesn't smoke. Okay, so helping her troubleshoot and find ways. This to you, after me talking to you and you sitting here perhaps not being a smoker, seems obvious. It's not always obvious to somebody who has the addiction and is trying to troubleshoot ways to quit. All right, second scenario. Patient's currently smoking a half a pack of cigarettes a day, same amount as before she found out she was pregnant, so she hasn't cut down. She's reluctant to quit and cites concern about withdrawal as a primary barrier. How do you assist? So, her primary issue is the withdrawal. Talk about the withdrawal. Okay, so this is what happens when your body goes through withdrawal. Okay? It's uncomfortable, your body's repairing, you know, really play up the fact that this is your body healing. When you're going through this craving, your body is healing from this. And here's some of the things you can expect. Okay, so this can happen here, this can happen here, that chart I put up for you before. Okay, which one of these are you most worried about? Is it the headaches? Is it the irritability? Is it the weight gain? You know, what is it? Try to identify and then talk about some ways to address that in particular. Okay, so in the past, say it was irritability. When you were irritable, what are some of the things besides smoking that helped with your mood? So again, trying to help and troubleshoot. We can also use the 5 A's for post-delivery care. Obviously, you can use this with anybody, but if we use it post-delivery, either to help a woman who was unable to quit during pregnancy quit, or to help a woman who quit stay quit, because a lot of people will go back to smoking after they deliver. All right, so remind them the risk associated with second and third-hand smoke exposure for that new baby that they just brought home. Encourage the patient to continue cutting down or remaining quit. So helping them find ways to continue that positive behavior change or the one that they want to make. Remind them again of the health benefits of quitting, remaining smoke-free. A lot of people will cite to you when they're pregnant as the reason they want to quit is they want to be a good role model for their child that they're having. Okay? Baby's home now, time to be a good role model if that was the important thing. And so talking about how that is important and how you can do that. Now I'm going to switch gears a little bit here and talk about safe sleep. And this, as I said, is very much related to smoking. This has been a very important recent topic in maternal child health. And there's been a change in terminology. Many of you may know this. I've been around long enough. I didn't really know about the change in terminology until just a year or so ago. You've probably all heard of SIDS, right? Sudden Infant Death Syndrome. Okay. There's a new term that we're seeing now, sudden unexplained infant death. You heard that one? That seems to be the umbrella term that we talk about any infant death where there is not a specific cause or a specific medical cause. And there's about 4,000 per year in the U.S. This is the leading cause of infant death. Okay, that is what? About a baby every 2.5 hours or so is dying of an unexplained death in the United States. That's a lot. Okay, about 50% of these sudden unexplained infant deaths are due to SIDS. And SIDS is specifically respiratory compromised and is sometimes impacted by sleeping position. And then about 20% of these sudden unexplained infant deaths are directly due to accidental suffocation or strangulation in bed, over and above the SIDS cases that may be from that too. All right, so what does this mean for all of us? All right, as I said, as many as 1/3 of SIDS deaths are directly attributable to prenatal smoke. Another 20% are from postnatal exposure. Okay, so you have half of the SIDS deaths that have something to do with sleeping. So clearly, if we can end pregnancy and postpartum smoking, we're going to have a big impact on the SIDS rates. Okay, in addition, there have been many safe sleep and health promotion recommendations that have also been combating SIDS. All right, so some of the health promotion. Now, if you think about SIDS and sudden unexplained deaths, they usually have to do with the respiratory system. So the one thing that you can do to decrease the rates of SIDS and sudden unexplained deaths is to boost the respiratory system of a baby. You don't want a baby who has a compromised respiratory system. So what do? If you don't smoke during pregnancy or postpartum, okay, you're already building the respiratory system. Eliminate the second and third hand smoke. Immunizations. Immunizations are very important because these are going to keep the baby from getting many illnesses that will cause respiratory compromise. Regular medical appointments, making sure that the child is healthy and growing, and breastfeeding. Okay? Children who are breastfed are, I don't know, like 4 times less likely to die of SIDS. It's a really high number because breastfeeding provides all of the immune boost. All right, so in addition to health promotion, I mentioned that there's things related to sleep. Okay, most of you know the campaign about reducing SIDS rate having to do with sleep position, which is what? Back to sleep, okay? The big back to sleep promotion the last 10, probably 15 years now, isn't it? Putting babies to sleep on their back has drastically reduced SIDS rates. So the face isn't scrunched down in something soft. You've got a weak little neck that can't pick up and can't turn. You've got a compromised respiratory system. The baby's got a cold. The nose is stuffed up. It's a recipe for disaster if the baby's on the stomach. So putting the baby to sleep on the back is crucial. Okay, in 2011, the American Academy of Pediatrics released their Safe Sleep Updates, and this is update from, I think, 2006 was the last one. Okay, number 1, all babies should be placed to sleep on their backs. We have our little baby here. Babies should always sleep alone, and this is the big push lately, the co-sleeping. Babies who are co-sleeping are much more likely to have problems getting their face trapped in something. Okay, so it's easy, and it's even worse when you're breastfeeding and you've got the baby in bed and you're getting tired, and it's hard. It's really hard to never co-sleep with a baby, but it's really important. Okay, babies should sleep in a crib or a bassinet only with minimal additional items. Okay, we are going to put, eventually, I hope, some of the infant bedding companies out of business because one of the worst offenders is those bumper pads. Okay, babies get their faces smushed up into those bumper pads and they can't breathe, but they're so cute. And when you decorate the room, you know, you want to have all of this stuff. This is really how the baby should be sleeping, okay? Nothing else in the crib. And here's a nice picture of the baby right next to mom, not in the bed with mom, but baby right there. All right, let me just give you some numbers related to this. Tennessee sleep-related deaths. We actually have a sleep death review panel in Tennessee. And so from 2009 to 2011, of the babies who died of sleep-related deaths, 84% were not in a crib or a bassinet. Huge. 68% were not alone, and almost half of them were not on their backs. Okay, so if we had followed, if everybody in Tennessee had followed these recommendations, we probably would have cut our sleep deaths by about 2/3. Okay, 2009 study, and this is why this is important to you. 2009 study of nurses, 72%, so almost 3 in 4 nurses knew that back sleeping was protective for SIDS. Okay, most of you piped right up with that when I asked the question, but only 30% regularly placed infants on their backs in the hospital. Okay, now there have been initiatives, and hopefully you will see this when you go out to do your clinicals, because all of the hospitals in Tennessee have just this last year pledged that in nurseries babies will be put to sleep on their backs. So you go look and see, because whether or not they say they're doing it and whether or not all the nurses are doing it is a different story. So take a look, okay, and you can be an advocate for this. Okay, parents are going to model what they see. So if a parent goes home and they saw the nurse putting the baby to sleep on the stomach, the nurse is the expert, the nurse knows how to take care of the baby, and so, okay, I saw her do it, it's okay, I can put the baby to sleep on the stomach. All right, so Dr. McCook found these wonderful t-shirts, which I thought I would show you. The front says this side up, and here's one on the back. It says this side down, please flip over. Okay, nice little reminder. We're trying to get some money together to get these in the local hospitals for parents to take home. Nice reminder, especially if you're sending the baby to grandma's house and grandma thinks, oh, it's fine, I put all my kids to sleep on their stomach. Throw the little t-shirt on when they go to grandma's so that grandma can remember. All right, here's some websites for you. Safesleep.10.gov has a lot of information on safe sleep. And this is the link here actually to the 2011 AAP requirements or recommendations for safe sleep.